Hi, everyone. It's Stephanie Trong with the patient story, and I have so much to be excited about today in introducing our guest, who's going to go through a lot with us, Dr. John Mascarenhas, who is the director of the Leukemia program at Mount Sinai, professor of medicine there, and also leads clinical research for MPNs. So, Dr. Mascarenhas, I want to say welcome.
Thanks for happening.
Before we jump into, we're going to talk about the basics of MPNs, the different types, and then talk specifically about myelofibrosis. I want to start by asking what drew you personally to one, becoming a doctor, and two, to this field in particular?
Well, I think in large part, probably becoming a doctor was an influence of my father, who was a doctor. Although he definitely didn't push me into this field, as most people would presume. But I think specifically into hemonc and specifically into malignant hematology and leukemia was very early on in my career. I was doing laboratory research, and I really loved it. I really loved understanding the science and actually, that's what I thought I was going to do was perhaps a PhD and do laboratory research. But when I went to medical school and actually started interacting with patients, I fell in love with it in a very different way. So it was a natural, I think, path for me to end up doing clinical research, which actually incorporates a lot of the laboratory knowledge that I gained over the years and interest in science and bringing to the patient directly through early phase translational research clinical trials. So that really, it just happened naturally, and I'm really happy about the way it happened.
Thanks for sharing that. And as a blood cancer patient myself, thank you for the work that you do. I noticed in the slides that use, you're always thanking the patients, who are participating in the clinical trials. And I think it's just so important, of course, to acknowledge that. So appreciate that. So we do have a lot to get through. In the first part, I do just want to ask you about the basics. I know there's a lot, but high level, in the lens of people who are just now dealing with an MPN, what are we talking about here? And what is the usual, message you give to your patients about what this means for them?
So MPNs, or myeloproliferative neoplasms, are chronic types of hematologic malignancies or cancers that involve the stem cells. And it's always important for me to convey that in a compassionate and soft way, but they are cancers of the blood. And that becomes important because I think often if we downplay or minimize the significance of these diseases as disorders, it actually takes away from the meaning and the potential morbidity and mortality that's associated with these diseases. So they are neoplasms, cancers recognized by the World Health Organization and the National Cancer Institute. They're chronic in nature, but potentially progressive in many patients. They are diseases that are originate at the stem cell level, but result in mature blood cells. So, for example, in the MPN, which is really a hodgepodge of diseases, there are two broad categories. Those that are pH positive, those are patients who have chronic myelogenous leukemia, and they have a very specific translocation between chromosome 9 and 22. That's the BCR-ABL translocation. And that's a very distinct group because there are fantastic drugs that can really treat that disease very effectively. And then there are the pH negative MPNs, and the three classic ones are myelofibrosis, essential thrombocythemia, and polycythemia vera, abbreviated MF, ET, and PV. And these three diagnoses hold certain biologic commonalities and clinical overlap, but also distinction. So ET is characterized by a high platelet count. PV is characterized by a high red blood cell count, but can also have a high white blood cell count or a high platelet count. And MF is characterized typically by low red blood cell count, anemia, and the white count and platelet count can be high or low. Myelofibrosis tends to have a big spleen, tends to have a lot of symptoms, but any of these diseases can. And they all share in common the predilection for clotting. So they're considered hypercoagulable conditions. So clots in veins, in arteries, like heart attacks and strokes, can be problems with these diseases. And they all have a potentially progressive path that can culminate into an acute myeloid leukemia, sort of a aggressive version of the disease. And there is a significant symptom burden that's associated with these diseases, and that's a target of therapy in many patients. There's the usual, I think, anxiety and challenges of living with a chronic disease that also plague patients with these diseases. So they're challenging diseases. They're rare diseases. And I think the fact that they are not easy to wrap your head around, in the sense that if you have breast cancer, if you have lung cancer, one can visualize or can imagine a lump in the breast, and then it could spread to a lymph node and metastasize. And that is a concept that's not foreign to a lot of patients and caregivers. But blood cancers are sort of weird in the way that they don't have a spot where they start. They're sort of metastatic at diagnoses. And people can walk around and look okay, but feel unwell. And they can hold the anxiety and fear of what tomorrow may hold, while still, being engaged in life and trying to carry on other responsibilities. So it's a challenging group of diseases, I think, to treat, to understand. But I'm happy to say that there's a lot of focus in this area, both in trying to understand the disease, the biology of the disease, and trying to develop treatments for the disease, both from a physician community perspective to patient buy-in, to academia and the FDA, and most importantly, pharmaceutical sponsors that bring the drugs to the clinic and allow us to do these trials.
Yeah, I know this is a fairly new area, and at least there's a lot of activity, it seems like, that's going on with all this research. And I know we're going to go into that a lot, delve into it. But in terms of the MF, the ET, and the PV, I know it's rare. So one, can you just sort of lay the land of how many people typically fall into each, and then in terms of treatment, how different is it? How many similarities are there?
So in each category, it's approximately one person per 100,000 new diagnosis. So, definitely not a very common type of disease. The prevalence increases with age. So the median age of these diseases is about 60, 65. But we definitely see people that are in their 20s at the time of diagnosis. And unfortunately, even a small subset of people, they're diagnosed at a very young age, like even as a 7-year-old, 8-year-old. So you can really have this diagnosis at any age, any ethnic background. There are some predilections for male or female depending on the subtype. But the presentations can be very varied. So sometimes the presentation is based on a clot. So patients will actually present with a thrombosis, a heart attack, a stroke, a clot in their legs or lungs, abdominal vein thrombosis, or sometimes they present because they have non-specific symptoms, what are called systemic or constitutional symptoms, like fevers, night sweats, weight loss, things that you can see in lymphoma and other related diseases. So not necessarily specific to MPNs. And then sometimes they're caught because they're on routine blood work. There are abnormalities, either high counts or low counts, and that brings the patient to the attention of a physician and then a hematologist. Usually a bone marrow biopsy is done to confirm the diagnosis. So it's a diagnosis. These diagnoses are usually made with a bone marrow biopsy in most cases, although I will say in some cases like polycythemia vera or even essential thrombocythemia, bone marrow biopsies are not always routinely done. But by diagnostic criteria, a bone marrow biopsy is part of that process. And then, in 2021, most patients are genotype, meaning that they get sequencing done of their blood cells, and we know what mutations, which are alterations in the DNA, are present, and that helps us also classify patients by whether they have certain types of driver mutations, and those mutations also provide prognostic input. And ultimately, we develop a diagnosis based on having certain criteria, a prognosis based on having certain risk factors, and then develop a risk-adapted treatment plan based on those factors. And depending on the disease subtype, so for example, for low-risk patients, low risk for having clots, ET and PV, sometimes it is an aspirin alone, and or therapeutic phlebotomy to keep the hematocrit below 45% in PV patients. And for patients who have higher risk disease, those are patients typically that are older in age or who've had clotting or who have a tendency to clot because of cardiovascular risk factors. we use what are called cytoreductive drugs, and they can be drugs like hydroxyurea, anagrelide, interferon alpha, or a JAK inhibitor like ruxolitinib. In myelofibrosis, it's a little bit more complicated because you can be put into different risk categories, and those risk categories can range from low risk, intermediate, 1, 2, or high risk, depending on different clinical variables and disease-associated variables. And in some cases, a fraction of the cases, patients can be watched if they're low risk. But in many cases, in most cases, patients are treated typically with a JAK inhibitor to address spleen and symptom burden. And then when appropriate, should also be evaluated for bone marrow transplant, which is the only treatment option that offers the potential to cure patients with higher risk myelofibrosis. And then, of course, there's a lot of interest in improving upon the therapies that we have. So clinical trials, when available and applicable, are also considered.
Thank you. I know it's a lot to summarize. And just really quickly, sort of translation, when you say spleen burden or symptom burden, you mean because there's an enlarged spleen or?
Yeah. Yeah, so when I say spleen and symptom burden, spleens get big. So in this disease, you have abnormalities in the stem cells of the bone marrow. Those cells no longer sit quietly in the bone marrow, and they start trafficking abnormally in the blood. And then they end up in other organs where they shouldn't normally be, like the spleen, and they start creating blood cells in the spleen. So the spleen becomes very big, and that's called splenomegaly. And that process is called extramedullary hematopoiesis. So blood cell development outside of the bone marrow, in the spleen or in the liver, hepatomegaly, and you get organomegaly, big organs. And of course, a big spleen can cause problems because A, it could be uncomfortable. B, it can push on the stomach, so you can have less space in your stomach, so you're unable to eat as much. And although that sounds good in a way, it's actually not good because people lose weight, and that's not healthy weight loss. And it can affect their bowels. It can affect just how they feel. It can affect the way they dress. Patients sometimes can't wear, pants normally because they're literally their physique can be changed by the contour of the big spleen. So it can really cause problems. And then beyond the spleen, people can have systemic symptoms: fevers, night sweats, weight loss, bone pain, itching can be a very significant problem, profound fatigue, headaches, rashes. So there can be a whole assortment of symptoms that can really reduce quality of life.
I'm so glad you're bringing all of this up because we hear about it, but it's really, I mean, people have to live with the day to day. It really interferes with, being able to live a quality of life. And
Yeah.
so, or a high quality of life. So before we move on to the treatment part, we hear from a lot of people who have MPNs and MF in particular, maybe. I mean, it's all rare. So it's really hard to diagnose, right? By the time people finally get diagnosed, it takes time, right? I mean, I just like to hear from you what your message is to people who might be feeling, frustrated or I don't know, something about the system. It's just unfortunately a rare disease we're dealing with, right?
Yeah, I think if there were screening tools, for example, a way of screening for these diseases, that would obviously make it faster and probably less anxiety provoking and frustrating for patients. But I definitely agree. There are patients in which it may take quite some time to come to the attention of the realization and the ultimately the diagnosis of an MPN, because they may be seeing neurologists for headaches. They may be seeing a gastroenterologist for GI distress. They may be seeing dermatologists for rashes and itching that can't be explained. And it sometimes takes time to get to where you need to be. And I totally can appreciate where some patients could be frustrated by that process. And some of it is because it is a rare disease.
I know screening is something that's a focus for other areas. Is it possible? Is it something of interest here for MPNs?
Well, right now there's no validated screening approach for MPNs. However, I will say that we know that people who have MPNs are more likely to have first degree relatives that are at risk for developing MPNs in their lifetime. So there's actually a lot of focus now by really great investigators in the field like Angela Fleischman, who are looking at family members and testing family members to understand what are the driving, perhaps genetic determinants for this increased risk, and will that help us understand the biology of the disease and the probability of getting it. And if someone has an MPN, then we recommend that their family members are are going through usual general health maintenance things, so not specifically going to a hematologist to get a bone marrow biopsy, but should have their blood counts checked, as they normally would as a general health maintenance process. Because the reality is many people, don't follow up with what they should be in terms of their usual general health maintenance.